Today, the second week of lectures is going to look at the beliefs and ideas that are sort of underlying and permeating all of what we do in healthcare. And it also will help you sort of understand why we're taking the approach we are, why some things are focused on and some things aren't. So one of the things that we want to think about is there's certain American ideas and beliefs within the system. One of them is that healthcare delivery is shaped by two beliefs. First, that science and technology are the end-all be-all, so we can get better medicine through science. The medical model, as we call it, means that we've taken this approach where it's doctor or patient. And the medical model means that advances are found through technology and science. So we're sort of looking at the outcome and impact on a disease. The medical model has also led to, it's like what you focus on is what gets the money. So we've seen huge advances in technology and medical science innovations. As a result, we just don't do things like combat disease or prevent disease. We deal with disease, but it's already a disease before we deal with it. So that could be an acute disease, sort of a one-off thing, subacute, an occasional thing, and then a chronic illness. And we've sort of moved from this illness model where you come in with something, we address it with science, we get it taken care of. And that was sort of what happened in the very beginning of medicine. We had fewer tools, which is ironic because we had fewer tools and fewer knowledge about how to do an intervention, fewer things we could give you. Whereas now, we have a lot more people who have what we call chronic illnesses. So that's something that's going to reoccur again and again, sort of like an up and down slide. And we're set up to deal with illness and disease versus a chronic illness, which is ongoing, long-going, and a consistent intervention that needs to be done. And some of those chronic illnesses could have been prevented if we'd focused on public health and prevention, but the medical model does not do that. It looks at disease, intervention, outcome. So it's sort of got three steps to it. Versus if you took a public health approach, and the public health is looking at a bigger population, whereas the medical model is only looking at the individual, then you would say, we're going to make sure that this bigger part of this population knows about healthy eating and lifestyle, and we do whatever we can to prevent diabetes or to prevent hypertension, versus the medical model, which says you come in with these diseases and we're going to give you interventions, medicine, technology, and we're going to treat them. The problem is chronic illnesses go on for a long, long time, so we have to have more and more technology to deal with the outcomes. Versus public health and preventive health, which would prevent what's happening, and we would see fewer and fewer people coming in with these diseases. But we're seeing the reverse. One of the things that's is that we don't look at a holistic range of preventions or interventions. We just look at medicine and technology as the intervention. We also don't really look at mental health. So we just see a disease, a physical manifestation, as the thing that we intervene with, versus mental health, which is the mental and the physical combined, because we do see that they influence each other. We really haven't also looked at mental illness as a chronic illness versus, again, with that disease model, as it's a disease, we do an intervention, it's solved, it's better. We're seeing that that is not the case with mental health, that you do need to treat it like hypertension or diabetes, and it goes over and shifts time and time again, especially with things like depression, and that we need to continue to treat it. We can sometimes prevent it or reduce the impact of it, but the medical model is not focused on that. What it's focused on is presentation, treatment, technology, done. So we've sort of got these two parallel tracks which are not helping each other. Second of all, we also see in the American healthcare system this belief in the individual. So we don't care about the group, we just care about you as you present. We treat doctors in hospitals versus where they're going to see you in clinics. We also don't seem to think that the government should be involved in delivering health. And that's one of the reasons why that public health is not as much financed as versus medical science, which is very much financed, and that's a bad thing. One of the things that we do need to talk about, though, is underlying this sort of individual disease model is that we think it's an economic good, a service, not a public resource. So somewhere like Great Britain sees it as a public good that everybody stays healthy. We don't. We see it as your individual responsibility to stay healthy. You individually use health care. The government's going to, or your insurance is going to pay for the individual. And what happens is that we think that it's determined by your access to health care is determined by money through working, versus you're supposed to get it no matter what, just because you exist. We have a clear distinction between the types of poor and affluent societies get it versus urban and rural, because we think it's up to the individual. We also have this sort of way that orients healthcare workers to the type of healthcare services they deliver. So again, it's on an individual basis versus, and only when you present with the disease, versus prevention, which we, until the Affordable Care Act, didn't really reimburse that much except for pediatrics. So we weren't going to reimburse you for getting immunizations. We would reimburse you for an office visit if you got the measles or the mumps. So again, it's that sort of weird way of looking at it individually versus if we prevent it from happening and we focus on you not getting hurt, not getting ill, we'd actually have better outcomes, we'd save more money. But that's looking at behavior as a group versus the individual, and that's not using the disease model, that's using a preventive model, which again, this system of beliefs is not really cohabitating with so much. The thing is that we've used all this medical technology and it's sort of zoomed ahead of what we could have done with preventive health and knowledge about that, what we could have done with public health and knowledge about that. And public health, actually, if you look at adding value, actually adds more value than the reverse, which is the individual health. One of the things that we commit resources to, and medical practice in general, is kept at the individual healthy versus the entire community healthy. And we've only financed that through individual insurance versus a global budget, which would look, again, these are the ideas and beliefs, how they outcome, looking at keeping the entire population healthy. So then we think of things like mental health as a whole person thing versus individual disease, treat, dissect, dilute. One of the things that's also underlined this, if you want to see sort of a dichotomy in action, is that sort of market justice versus social justice about how we deliver healthcare. And in the market justice view, healthcare is an economic good, and it operates under free market conditions. So it assumes that markets are efficient in allocating health resources to those people who want to put their resources towards it and want to pay for it. Social justice sees it as a social resource. So social justice is going to say that the government has to be involved, not just the individual and the individual's employer, but they have to be involved, and we have to allocate resources to make sure that everybody stays healthy, no matter where they start from, rich, poor, rural, affluent. Medical care is regarded as a basic health right for all to be healthy in a social justice model. And in a social justice model, the sort of way in, or the barrier to entry, is you're just alive and you were born in the right country. For the market system, it is money. You have to have enough money to pay for it, or you have to have a job that provides it. Again, usually jobs that have a higher wage are more likely to provide the health care. And even when you get health care through insurance through your employer, the more money you make, the more you can actually afford. So we sort of see this market system playing out now, even under things like the Affordable Care Act. One of the problems is, however, is that they don't really complement each other, and they don't really, you sort of get one or the other, and it does preclude other interventions. So they do collide when we get a lot of people who are uninsured, when there are people who cannot afford health care, so Medicare and Medicaid is one of the ways we get that. They can help each other if they enable the entire population to get access to health care. Again, that sort of happens with the Affordable Care Act because everybody's supposed to have insurance, but it's not fully diluted and done out because you still have to have the money to access the health care. Sometimes when you see like Stroger, which is tax supported by Cook County, then you're able to see that sort of social good of you can get health care no matter what your income, you just have to come here. There are conflicts though that arise because the healthcare system will end up in the market justice system rationing out health care depending on what you can afford versus what you actually need. And again, it's still focusing on the individual level. One of the problems too with looking at the market versus the social is in the market justice system, we're assuming that it has economic principles at work. So that means that you should be able to get access to low cost, easy to understand information. No one in the healthcare system can do that. You can't understand when you're going to need health care. You don't understand the medicines. You can't say to your doctor, pharmacist, why don't we do this versus that? Because I know what the outcomes are and what the cost-benefit analysis are. No one's doing that kind of analysis in a way that's easy to understand. Everyone's sort of in their different silos working it through. Versus if you had a global budget like somewhere like Great Britain, they're going to allow only medicine that's been proven to work and been effective within their patient population to be the one that they support and they give money to, so that everybody can have access to it. So you're not going to get the access to the special new drug that may or may not work. We don't know if it's effective. There you're only going to get outcomes and measures that actually work. One of the sort of backdrops that people talk about with social justice is that, yeah, everybody gets it and everybody gets a sort of minimum standard, but you have to wait. Again, I think one of the things we need to keep in mind when we look at the market justice system, how it works in the United States, is that even if you have insurance, if you're sick today or you want to see somebody and you're not already their patient, you have this sort of illusion of choice of who you can see because you can't see anybody if they're not on your insurance, otherwise you pay more. You also have this illusion that you can see people whenever you want, and that is not usually the case. If you're a new patient, you can wait up to 30 days, if not more. If you have an incident-based thing, you might even just go to like an acute care center because you can't get into your doctor. So we sort of have this whole different subpopulation of providers, minute clinic, places like that, because the doctors can't see you. So that sort of illusion of choice and illusion of access does not exist in the market system either. Again, in part because of the uninsured, in part because we don't have enough providers, in part because we're not doing that sort of preventive health and public health, which reduces the amount of sick people and the level of sickness they have coming in. So these values and beliefs underlie everything that happens. And if you're looking at a market justice system, one of the things to keep in mind too versus social justice system is, in a social justice system, you have health insurance no matter where you go. So you want to start your own business, you want to change jobs, to get more opportunities, you can do that. You won't jeopardize your health insurance. You have a pre-existing condition, same thing. In a market justice system, even under the Affordable Care Act, you still are going to have decisions to make about where you get your insurance, who has the best plan, and can you afford to start your own business and then pay for your own insurance versus your employer who's getting a special discount because, again, they're cutting a deal in the market system with, I'll bring you 10,000 healthy employees, you give me it at this rate. And that's the plan you get from your employer. But they've got it at a lower down cost. They've paid for 70%, 70 to 80% of your real healthcare costs they pay for through the insurance market that they have with the hospitals and the doctors. So no one knows what it really costs. And the real costs are protected from you. Remember, we talked about that last class. And, excuse me, you don't have enough access to information to even make these decisions even if you wanted. And with healthcare, you don't know when you're going to be sick. So you can't sort of plan ahead and save ahead and then be able to budget further. So there's a lot of dichotomies at work of both of these things, and it really does underline and sort of weigh down our healthcare system. And you need to know that as an administrator in order to make these drastic changes and to explain the system to each of the players.